I'd like to introduce Dr. Babar Basir from Henry Ford Hospital, who's going to talk to us about the Detroit Cardiogenic Shock Initiative. Dr. Basir.
Good morning, everybody. Thank you very much for the invitation. I'm here on behalf of Dr. Bill O'Neill, who's my mentor, and I'm going to talk to you a little bit about the Detroit Cardiogenic Shock Initiative. Here's all of our contact information. If you have any questions or concerns, I'd be more than happy to talk to you about all of that today. I have no disclosures for this talk. So we all know that AMI and cardiogenic shock is a growing problem, and unfortunately, over the course of the last 20 years, we really haven't gained a lot of momentum in our ability to improve the overall outcomes, which are, essentially surviving the hospital stay. And one of the things that we did is we went back and we looked through the IQ database and kind of looked at patients with Impella and tried to figure out what factors were most associated with survival, try to combine them together, and essentially derive a regional protocol that we could implement prospectively and see if we could actually gain some better survival outcomes for these very difficult to treat patients. And when we did that, we essentially saw a few factors. One is that survival is improved with the less amount of inotropes and vasopressors that you're on. Now, this could be a misleading slide. Clearly, patients who are sicker are always going to be on more inotropes and pressors, but there's likely some component of problems with inotropes and vasopressors, whether it's increasing oxygen consumption, being arrhythmogenic, and other factors. Similarly, one of the most profound things that we found out was that the earlier these patients get treated, both with revascularization and with support, the better they do. And so it's clear cut that just like when we talk about door to balloon times in STEMI situations, in cardiogenic shock, we really have to talk a lot about door to support and door to unload times. And so survival in this group, if you can get to them within the first hour and 15 minutes, is remarkably different than when you see these patients 2 to 4 hours later. Another thing that we noticed was that these patients do better when the hemodynamic support is placed prior to the coronary intervention. So this group consisted of a large number of STEMI patients as well, and the reperfusion injury, the added ischemia during the PCI seems to be a factor. And so we've essentially kind of coalesced these first things, early support times, support before PCI, and kind of combined them together in our protocol. And we are firm believers that anybody who gets a hemodynamic support device deserves invasive hemodynamics. And what you can see is that patients who are evaluated with invasive hemodynamics by right heart catheterization, they tend to do better both in the IQ database and CVAD registry because of the information these invasive hemodynamic measurements provide us. So coalescing all of this together, what we did was we formed the Detroit Cardiogenic Shock Initiative. So this was 4 hospital systems with 5 total hospitals located in the metro Detroit area, hospitals which are essentially competitors of one another, hospitals that are in close proximity to one another, but under the mentorship and leadership of Dr. O'Neill, we essentially coalesced these programs, and everybody agreed to treat the patients according to the protocol that I'm going to describe to you today, and then I'll share with you a little bit of our outcomes. So the first thing was that cardiogenic shock is clearly a heterogeneous field, and so we're focusing on AMI and cardiogenic shock, but even to take it a step further, we wanted to mimic the patients that are seen in prior randomized control trials. And so what we did was we included, despite it being kind of a registry-based study, we included inclusion and exclusion criteria to make sure that when we're talking about our outcomes, that everybody is aware of the specific patient population that we are studying. And so these are the exact inclusion and exclusion criteria used by the original shock trial. The only thing that we added is that we did not want patients who had previously been treated with intra-aortic balloon pumps. We thought that would be a confounder, and to be quite honest with you, at least in the Metro Detroit area, these patients are on balloon pumps for 6, 12 hours before they get to us, and so it really takes away from the aspect of early mechanical circulatory support. And so what we did is this is a protocol-driven treatment. Everybody agreed to treat it according to this way, but clearly in the implementation of that, every individual decision was based on the operator's preference. And so there's early identification of shock, whether it's in the emergency room, immediate cath lab activation, access, basic hemodynamics, make sure that our LV-EDP is greater than 15, and essentially a rapid support system. And so we have door to support times which are less than 90 minutes. That was our goal. And like I mentioned, invasive hemodynamics. And the main measurements that we're kind of looking for are to make sure that everyone calculates a cardiac power output and a pulmonary artery pulsatility index, the PAPI. And based on these variables, it gives clinicians an idea of the level of support that they need, whether there's right-sided dysfunction. And one thing I want to kind of emphasize and make sure no one takes home with them is that I don't want anyone to go home and say, Babar told you that if your PAPI is less than 0.9 or your cardiac power output is less than 0.6, that you need to put in a transcaval 5.0 Impella. So we do that at Henry Ford sometimes, but don't take that with you. These are guidelines and measurements to be able to kind of help in the decision-making algorithm. But ultimately, everyone needs to be clinicians and make sure that that is appropriate for their specific patient. So as soon as we get the hemodynamic support and we try to decrease vasopressors and inotropes guided by our invasive hemodynamics and right heart catheterization and see how the patient does. And if there is issues with the amount of perfusion and support and unloading that the patient is getting, then we have hopefully an ability to rapidly evaluate that, and we prefer to do a lot of early escalation, whether that's with 5.0 Impella or ECMO or the various other devices that are available for us. And so the quality measures that we really wanted to evaluate and look for are the door to support time less than 90 minutes to establish TIMI-3 flow, wean off vasopressors and inotropes as possible. We want to maintain a cardiac power output of 0.6 watts or higher, ideally. And our goal was to improve survival to over 80%. So these are our demographics for the 41 patients that we've done in just under one calendar year. And I wanted to compare our kind of values with other trials. And remember, when we look at this, we want to be able to know of which patients we're studying. So our patients have a similar inclusion and exclusion criteria as the original shock patients. And so one of the comments that I get very frequently in discussing this is, well, what about the results of the IMPRESS trial? And so I just want to kind of clarify the different patient scenarios here. So we talked a little bit about Detroit CSI and the shock trial, but the IMPRESS trial really a much sicker cohort of patients. They were younger, but they were all mechanically ventilated, all on pressors, and the biggest thing that you'll notice is that 92% of them had a cardiac arrest, and many of them had prolonged resuscitation times. And so the cohorts are different, and I think when you go to the results, you should be able to kind of understand and look at that as well. And so our trial, similar to other trials, was clearly patients who were in shock, not as impressive as the IMPRESS trial where their median lactates were 8.2, but we had a median lactate of 4.7 with hemodynamics consistent with cardiogenic shock. And the reason that I emphasize this is that we had a very favorable outcome. And one of the things that I think we are sensitive about is that having conducted the study is that we really, this was an all-comers trial based on our inclusion and exclusion criteria, and we were lucky to have a very good outcome. So in this original pilot study, we had about 55 forms filled out. 14 were excluded because they did not fit our definition of AMI cardiogenic shock, and because they were outside of that scope. And out of these 41 patients, we still had a very sick cohort. 15 patients with in or out of hospital cardiac arrest, and 8% of these patients were getting active CPR at the time of Impella, and what we found was a 76% survival, so 31 out of the 41 patients survived, and that's in comparison to the other trials that we've talked about a little bit. And so just in time's sake, this is the improvement in cardiac output, power output that we had over the course of our patients. Our survival was better than the survival that we had previously within the Metro Detroit area as well. It's not a great control because these aren't the exact specific inclusions and exclusions that we've concluded in our study, but regardless to say, the biggest sign of hope for us, though, was that our adherence to the protocol and our outcomes are getting better and better. So we originally implemented this, and as you can imagine, it's from 4 different hospitals with multiple different providers. And so our first patients, even a quarter of them didn't even get a right heart catheterization. And so as time has gone on, these patients have done better and better, and our adherence and our overall ability to stick within the protocol has also been slightly better. And so hopefully what I've presented to you today is at least one regional protocol and algorithm that shows that with rapid invasive hemodynamics and the ability to obtain the hemodynamics and delivery of early mechanical circulatory support, I think we can actually move the bar a little bit on outcomes in cardiogenic shock. And so, we always break down things as easy as possible. So there's ABCs of a lot of things, but the ABCs in our lab is to get access, get hemodynamics, put in a support device, take off vasopressors as quickly as you can, and if needed, do an early escalation to a larger support device if necessary. That's all. Thank you for your time.
Dr. Basir, thank you very much for that really elegant talk. You showed that in the second half of the cohort, there's been a move to do Impella support pre-PCI. And I'm wondering, is that a clinical decision just made by the operator, or is that based on work we've seen published here, or what is the nidus behind that?
Well, we've seen actually multiple studies now, mostly looking through retrospectively at the CVAD data, that patients who got support before their PCI did better. And so that was our original recommendation with the protocol. What's ended up happening is that every operator has to make their own clinical decision at that time, specifically with that patient. But generally speaking, I think having gained the experience of doing it over the first 20 patients, seeing the outcomes over the course of the last year, more and more operators are comfortable putting in the device before they start their intervention. As I said, most of these patients are STEMI patients for, a 65-year-old to change their outcomes of door to balloon time, and the fixation with that, sometimes it becomes a little bit difficult. So,
I guess that was my follow-up question, the percentage of NSTEMI versus STEMI in your cohort? Of an NSTEMI versus STEMI in the cohort?
There is a minority of NSTEMI patients. I believe it's right around 20% or so.